Okay. Good afternoon, everyone. My name is Rocio Torres, and I am with the Overdose Data to Action States OD2AS at the Arizona Center for Rural Health. It is my pleasure to welcome everyone to our webinar, Center for Disease Control and Prevention Clinical Practice Guideline for Prescribing Opioids for Pain 2022. Before I introduce our speaker, I want to share some housekeeping items with you. Please use the chat to enter your questions. Our speaker will address your questions at the end of her presentation. We will be recording this webinar and post the link on our website in the upcoming days. Visit the Arizona Center for Rural Health website for more information. And this is our land acknowledgement. The University of Arizona is as follows. We respectfully acknowledge the University of Arizona is on the land of territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the Otohom and the Yaquim. The university strives to build sustainable relationships with Native nations and indigenous communities through education, offerings, partnerships, and community service. Our speaker, Dr. Mary Tulinnye, is a distinguished psychiatric nurse practitioner with a Doctor of Nursing Practice degree from the University of Arizona, Wisconsin Madison. She has dedicated the past 9 years to serving at the Mohave Mental Health Clinic in Bullhead City, Arizona, as part of the National Health Service Corp. In her role, Dr. Mary has provided evidence-based care to individuals facing addiction challenges. Outside of her professional work, she enjoys exploring the beauty of the Western United States with her family. Welcome, Dr. Mary, and I will share the floor in a second. Okay, and now you can share your slides.
All right, thank you so much. All right, Maria, do you see my slides well?
I do.
Okay, very good. All right, well, welcome everyone, and thank you so much for attending this webinar this afternoon. I know your lunch hour is precious, quickest hour of the day, right? So I appreciate everybody's motivation to enhance your understanding of these clinical practice guidelines for the safe prescribing of opioids for pain in the United States. So just to thank the University of Arizona and the Center for Rural Health for inviting me to speak today. And we see the mission of the Arizona Center for Rural Health is to improve the health and wellness of Arizona's rural and underserved populations. And they definitely have lots of projects that are facilitating this, and I'm proud to be able to work alongside them and deliver this presentation today. So I am being paid to conduct this webinar, but I have no other financial disclosures to report. We're not going to be talking about any branded products or specific medications. So I just want to take a moment to pause. I know if this is your lunch hour in clinic, you're coming from busy time taking care of patients, if you're in school or at home with your family. So if we could just pause and take a few deep breaths and recognize that self-care is professionalism. And we also want to recognize that pain and substance misuse impacts many of our lives. I'm sure that there's few people in the audience that have not been directly impacted or know someone closely who's been impacted by opiate misuse, opiate overdose, and death. I myself lost a nephew to an accidental opiate overdose, and it really imprints grief on the family. So in 2023, 105,000 people died from a drug overdose in the United States. And the death rate nearly quadrupled between 2003 and 2022. So that's the sad reality, but the positive part of this is that we know as medical professionals that prevention, harm reduction, treatment, and recovery work, as evidenced by the number of people who are dying from overdose is finally decreasing. So we're finally starting to slowly turn that trend around. And more than 29 million adults who perceive that they ever had a substance use problem, 72.2% or 20.9 million consider themselves in recovery or recovered. And I definitely can attest to that in the work that I do at the clinic with medication-assisted treatment of individuals challenged with substance dependence. So to be a good presenter, you always tell people what you're going to say it, and then review what you said. So we'll start out with our outline, background and relevance of these recommendations, introduction and history of the 2022 clinical practice guidelines for prescribing opioids for pain. These came out in November of 2022 and were an update on the original CDC clinical practice guidelines that came out in 2016. Then we're going to delve into the 12 actual recommendations with implementation diagrams into healthcare settings and conclude with some resources and some time for questioning. So you're going to get a lot of information in this slide. Of course, I'm not just going to be reading it off, but highlighting the pertinent details. And at the end of this presentation, you're going to have so many links that can give you additional resources for practical ways that you can implement these recommendations in the workplace. So our goals today are to understand the relevance of the CDC clinical practice guidelines for prescribing opioids for pain. And number two, demonstrate ways the guidelines can be implemented to healthcare settings. So the practical application of these guidelines. So starting with background and relevance. So we really have this formal definition of pain, but anyone who's lived more than a day has an idea of what pain is. So the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or describes in terms of such damage. And we know that pain is classified as three types: acute, subacute, and chronic. And we'll be talking a little bit more about that as we progress. And pain is relevant to medical providers because pain is one of the most common reasons that adults seek medical care in the United States. In 2019, 1 in 5 adults reported that they suffered with chronic pain, and 1 in 14 adults experienced high impact chronic pain, defined as having pain on most days or every day during the past 3 months that limited their life or work activities. In 2011, the economic costs of chronic pain were estimated to range from 560 to 635 billion in annual direct medical costs, lost productivity, and disability. So we know that pain definitely is a real phenomenon. It can be debilitating, greatly reduced quality of life. I always like to add here that as we think about pain and we have this standard definition and a basic understanding, to keep in mind that pain involves two elements. Pain involves that physical sensation of the painful stimuli, but then also the emotional response to pain. So as human beings, we experience pain, always those two phenomena are going on. So keeping that in mind and acknowledging that individuals who already have challenges regulating their emotions, who possibly have propensity towards depression or severe anxiety, are going to have that much more of a challenge regulating pain. All right, so pain is a complex phenomena and it's influenced by multiple factors. And there's multiple reasons why we can have pain and multiple factors that include biological, psychosocial, and other societal factors. This complexity means that substantial heterogeneity exists in the effectiveness of various pain treatments, depending on the type of the underlying pain or the condition being treated. And we know across the board in all disciplines of healthcare, we no longer embrace that one size fits all approach. And because so many factors go into the pain experience and perception of pain, we definitely have to tailor our approaches to treatment. Prevention, assessment, and treatment of pain, it's a persistent challenge for clinicians. And that kind of goes without saying. At the same time, as we work to mitigate some of the factors that led up to the opiate epidemic, we want to recognize that pain often goes unrecognized. And some persons, for example, members of marginalized racial and ethnic groups, women, older persons, people with cognitive impairment, or who maybe have receptive or expressive language disabilities that can't adequately communicate their pain, or people with mental and substance use disorders that may be stigmatized, can be at risk for inadequate pain treatment. And we definitely want to do everything we can to mitigate that. So data underscores opportunities for addressing specific long-standing health disparities in the treatment of pain. And so one example of that could be that research shows patients who identify as Black or African American are less likely to be referred to a pain specialist when they come into the clinic with pain. And then geographic disparities can contribute to increased use of opioids for conditions for which non-opiate treatment options might be preferred but are less available. And that was surprising to me when I first reviewed that research and those statistics, that if you're being treated in an ER in a rural area, you're more likely to be prescribed opiates as opposed to being referred for physical therapy or some other non-pharmacological pain treatment. So this pain, the phenomena of physical pain, is felt even sharper when systemic failures are internalized as personal ones, which can happen in the stigmatization of marginalized groups. And because of the clinical, psychological, and social consequences associated with pain, including limitation in activities, lost work productivity, reduced quality of life, and pervasive stigma, like we've mentioned, it's essential that clinicians have training, education, guidance, and resources to provide appropriate, holistic, and compassionate care for our patients with pain. On the other hand, we have to acknowledge that communities that are impacted by these constraints also have strengths that can be used in their favor. So we always want to embrace that strengths-based approach. For example, rural communities, of which I practice in a rural underserved community in the Mohave Desert region of Arizona, we are resilient and have strong interconnected social relationships. We have critical access hospitals, rural health clinics, and federally qualified health centers, along with tribal operated healthcare sites. All right, so just to share with you some relevant statistics in the United States. In 2020, among those reporting misuse during the past year, 64.6% reported the main reason for their most recent misuse was to relieve physical pain, not to become intoxicated, compared with 11.3% reporting to feel good or get high, and 2.3% because I am hooked or I have to have it. So once individuals have been on the opiate for really a short amount of time, that feeling of euphoria really is dissipated, and it just becomes an everyday effort to obtain the opiates to prevent the very noxious stimuli of opioid withdrawal. In 2020, prescription opioids remain the most commonly misused prescription drug in the United States, unfortunately. Unfortunately, for many reasons, and one of which is there's definitely the risk of lethality. All right, so addressing healthcare disparities and promoting healthy communities. So frameworks for healthy communities, the CMS framework has 5 priority areas. So priority number 1, expand the collection, reporting, and analysis of standardized data, assess causes of disparities within CMS programs, and address inequities in policies that close the gaps, build capacity of healthcare organizations and the workforce to reduce health and healthcare disparities, and advance language access, health literacy, and provision of culturally tailored services. And the priority number 5, increase all forms of accessibility to healthcare services and coverage. So healthcare services without that can't be accessed are really, services that are wasted and money that is wasted. So in response to some of the statistics that we talked about, national and statewide, some entities and organizations like CMS, they've advocated and developed frameworks to further advance health communities to expand coverage and improve health outcomes. CMS recognizes that addressing healthy communities and comes from addressing the needs of healthy individuals, and it should underpin efforts to focus attention and drive action on our nation's top health priorities. As we saw earlier, healthcare disparities contribute to increased use of opioids and inadequate pain management and access to prevention, assessment, and treatment. It's imperative that we pay close attention to guidelines like the ones that we'll talk about in a moment to better treat communities. So CMS developed 5 priorities that range from data collection and use to accessibility to healthcare services and coverage. We'll see later how we can connect the CDC guidelines with these priorities. And I think a great thing to think about with these guidelines is that the information that they contain wasn't just collected from doctors, but from a multidisciplinary team of social workers, addiction specialists, pharmacists, and also the individual patients themselves. So taken together, the previous factors underscore the need for an updated clinical practice guideline on appropriate opioid prescribing for pain and pain management. The CDC recognized the need for a national guideline on pain management that could improve appropriate opioid prescribing while minimizing opioid-related risks, and released the CDC practice guidelines for prescribing opioids for chronic pain. So as I said earlier, the original guidelines came out in 2016, and then in 2022, November of 2022, the guidelines that we're talking about today came out. And with the newer guidelines, they really wanted to emphasize that it is a clinical tool, one of many tools that we have available to us as prescribers and clinicians to improve communication between clinicians and patients, and really to empower prescribers and patients to make informed, patient-centered decisions related to pain care together. And it really wanted to really give us opportunity to have in one place a systematic review of the evidence so that we can deliver what we're all striving to deliver, that's evidence-based care based on evidence-based recommendations. So the clinical guideline is intended to be flexible to enable person-centered decision-making, taking into account patients' expected health outcomes and well-being by improving efficacy and safety of pain treatment, mitigating pain, of course, the original goal, and improving function and quality of life for patients with pain. And a lot of times when you hear about success with pain interventions, it's not just the mitigation of pain, but the improvement in quality of life and overall functioning that we have to focus on. And we really, really want to reduce the risk associated with opioid pain therapy, including opioid use disorder, and unfortunately overdose and death. So the CDC practice guidelines, their scope and audience is applicable for outpatient settings. So it's outpatient settings that include clinic offices, clinics, and urgent care centers. And it's intended for primary care clinicians, dentists, neurologists, anybody that's treating acute, subacute, chronic pain in the outpatient setting. Now, if you're on an inpatient in an ER or a surgery center preparing that patient for discharge, then these recommendations are applicable to you, but they're not applicable on the inpatient setting. And they're also not related to the treatment of pain for specific cases such as sickle cell disease or oncology patients, and definitely not to restrict palliative care or end-of-life care access to pain medication. They're not focused on opioids prescribed for opioid use disorder, things like Suboxone, naltrexone, methadone for opiate use disorder. These guidelines are not designed to enhance medication-assisted treatment for opiate use disorder, and they're not applicable to providing care to patients who are hospitalized, as I said, or who are in an emergency department where they're looking to be admitted to the inpatient setting. So when the 2016 guidelines first came out, I was working at the Psychiatry Outpatient Clinic in Bullhead City, and like a lot of good initiatives done on a nationwide scale, sometimes they can overcorrect. And you saw many providers who were understandably concerned with the opiate epidemic and the statistics of the deaths, the unintended deaths coming through, really use these as a strict outline of how they needed to prescribe. And unfortunately, you saw doctors like rapidly tapering people off of opiates and possibly moving like in a not helpful direction. So the 2022 guidelines really try to emphasize that they're recommendations. And these recommendations, they are grouped into two different types of grouping. So 12 recommendations are either category A and B. And category A means that these are general recommendations. They apply to pretty much everyone universally in the outpatient setting, adults, any adult. And then B are more targeted to specific groups of individuals. And then the 4 evidence types based on like number 1, having the strongest evidence base, and then downward from there, if that makes sense. So the recommendations cover 4 areas: determining whether or not to initiate opioids for pain, selecting opioids and determining dosages, deciding duration of initial opioid prescription and conducting follow-ups, and assessing risk and addressing potential harms of opioid use. So each of the 12 recommendation statements is followed by considerations for implementation and a rationale for the recommendation. The implementation considerations offer practical insight, context, and specific examples meant to further inform clinician-patient decision-making for the recommendation. And again, they're not meant to be rigidly followed or inflexibly followed. So there's 5 guiding principles that should broadly inform implementation across recommendation. So as you hear these recommendations, you want to keep in mind these principles that should guide implementation for the individual clinician and for clinics and healthcare organizations as a whole. Number 1, acute, subacute, and chronic pain needs to be appropriately assessed and treated independent of whether opioids are part of a treatment regimen. Number 2, recommendations are voluntary for the clinicians, and are intended to support and not supplant individualized person-centered care. Flexibility to meet the care needs and the clinical circumstances of a specific patient needs to be paramount. It's a multimodal and multidisciplinary approach to pain management, attending to the physical health, behavioral health, long-term services and supports, and expected health outcomes and well-being of each person is critical. So keeping that well-being and quality of life of each person at the forefront. And special attention should be given to avoid misapplying. Again, here's where we stress that you don't misapply the clinical guidelines beyond its intended use or implement policies, healthcare organization policies purportedly derived from it that might lead to unintended and potentially harmful consequences for patients. And last of these guiding principles is that clinicians, practices, health systems, and payers, insurance companies are involved in this operation. They should vigilantly attend to health inequities, provide culturally and linguistically appropriate communication, including communication that is accessible to persons with disabilities, and ensure access to an appropriate, affordable, diversified, coordinated, and effective non-pharmacological and pharmacological pain management regimen for all persons. Okay, so of course this sounds like a lot, right? It is a lot, it is more than a mouthful, and we haven't even gotten into the 12 recommendations yet. So as you hear, we're gonna be guided by these principles for implementation. You're gonna think of one small thing, like if you could walk away from this presentation with one small thing that you have a better understanding of, or one small thing that you could use to implement in your work setting, or that you could educate someone in your practice on, that would be great. We're going to start small. We're going to be clear, delineate roles. It has to come as a multidisciplinary team, and we'll talk about that. You're unable to integrate many of these recommendations, like one person, one physician, one nurse practitioner alone cannot implement all these recommendations without the support of a team and clinic policies in place that facilitate their success. We need to set achievable and reasonable goals. And of course, be kind to yourself and others in your organization. As a mental health professional, I really feel, or any medical professional, right? Because mental health is health and wellness. We need to really be setting an example of good self-care to our peers and to the community. And knowing that change takes time and consistency. Now, one good thing about these changes, we talked about those first implementations, the CDC recommendations in 2016. This came as a shock to the public when doctors really started withdrawing opiate medications, withdrawing benzodiazepines. But by now, there are very, very few people in the public that aren't aware of the opiate epidemic and do have some knowledge about the potential danger of these medications and desire to kind of mitigate the risks of the unintentional overdose opiates. So we have a nice quote here, and I love quotes. You don't have to see the whole staircase, just take the first step, by Martin Luther King Jr. And what I like to use, a saying that helps me, is we don't have to let the perfect be the enemy of the good. We start implementing these small steps, and we do our very best every day. So recommendations 1 and 2, determining whether or not to initiate opioids for pain. So non-opioid therapies are at least as effective as opioids for many common types of acute pain. Clinicians should maximize use of non-pharmacological and non-opioid pharmacological therapies as appropriate for the specific condition and patient, and only consider opioid therapy for acute pain if benefits are anticipated to outweigh risks to the patient. Before prescribing opioid therapy for acute pain, clinicians should discuss with patients the realistic benefits and known risks of opioid therapy. So I can't tell you how many individuals that did not enter pain management with addiction issues will tell me, I had no idea. I had no idea that taking this pain medication would lead to my dependence and then ultimate withdrawal and problems getting off of the medication. So even though that knowledge is more out there in the public, every patient deserves their prescriber to take time with them and explain the risks, and that the risks are legitimate and really could happen to anyone. Risks such as not combining opiates with other sedating medications that they may be getting prescribed from other doctors, not prescribing opiates to be used along with alcohol, that can be deadly. Letting patients know that many times younger people are obtaining illicit opiates from their grandparents or from their parents, that these need to be stored safely, and considering, of course, all non-opioid therapies before you even discuss the addition of the opiates. And so non-pharmacological therapies can include the obvious NSAIDs, our non-steroidal anti-inflammatory drugs, and acetaminophen, or neuroleptic medications such as gabapentin, which is Neurontin, or some of the SNRI medications like Cymbalta, which is duloxetine. They can be very effective for treating pain. Even with those, we want to use that education and let people know the recommended daily dose of acetaminophen, and really work to ensure that those options are being given to patients before we start recommending opiate therapy. And one thing that I have noticed in Bullhead City is that more and more, so physical therapy has been around like for many years. My entire adult life, I've been working in healthcare, and we always knew physical therapy was an option. But really now, at least in my area, you see it being utilized more and more as a first line treatment. And for whatever reason, patients seem more accepting and committed to physical therapy. And I'm astounded the success that people can have. Elderly people with significant orthopedic pain can have a lot of success with physical therapy. Also utilizing topical ointments and creams for pain that would respond to treatment of that nature, ice, elevation, rest, all of those things that might seem obvious to not us might not be so obvious and need to be recommended to our patients. So we want to, at the same time as we're trying to do this, consider health equity considerations, verify accessibility to non-opioid therapies and non-pharmacological alternatives. So physical therapy might not be an option for your patient that lives, in a rural area 100 miles away from the closest physical therapy setting. Also, for our elderly population that's on Medicare, those $10 copays can add up. And so finances might not make it accessible to certain members of our population. And even though it might not come to us that paying for acetaminophen or NSAIDs or a topical Bengay is not easily accessible for many of our patients, even though it might seem cheap to us, that $5-10, they just don't have it. So if their insurance won't pay for it, they don't have access to those much safer, adequate means of pain. So just keeping that in mind and ensuring that pain management with non-opioid alternatives reflects patient preferences, values, and understandings of benefits and risks in the language used by the patient. Report new opioid prescriptions taken by patients. So I think like if you're doing your med reconciliation before you get with the patient, that can be helpful. And develop and propose a culturally and linguistically relevant tapering system. So just like many years ago in healthcare, it was introduced to us that when your patient is admitted, that first day, that first hour, you're starting with your discharge planning in the era of managed care. The same kind of principle applies to if we choose to initiate that opiate prescription. Immediately up front in the conversation, we are talking about how we're going to taper that patient off and letting them know that the longer they remain on that medication, the more difficult it may be. So again, just stressing in recommendation number 2 that non-opioid therapies are preferred for subacute and chronic pain. Clinicians really need to maximize use of non-pharmacological and non-opioid pharmacological therapies as appropriate for the specific condition and patient. And we're only considering initiating opiate therapy if the expected benefits for pain and function are anticipated to outweigh risks to the patient. Before starting opioid therapy for subacute or chronic pain, clinicians need to discuss with patients the realistic benefits and known risks of opioid therapy. It should work with the patients. We need to really work with our patients to establish treatment goals for pain, function, and should consider how opiate therapy will be discontinued if benefits do not outweigh risk. So I always say to my patients sitting in front of me, and this is usually when we're developing our psychiatric treatment plan, that I'm not here to tell you what to do. I'm here to listen and assess, and then teach you about the options that are available, their risk versus benefits, and then we'll come up with a plan together. Now, people who are in pain management may say that's easier said than done, but I think we always keep the patient as their own best expert on their life and their quality of life, considering that I am at the point, as a prescriber, I am the best expert on these medications. And I want to help you, but I don't want to harm you. And so that's my first intention, to do you no harm, but to adequately treat your pain. And so before you prescribe or even consider prescribing any opiate medication, I would say prior to prescribing any medication, I do it prior to my patient coming into my room. I review the prescription monitoring website. In Arizona, we call it the PMP, but now there was one state, I think South Dakota maybe, was a little bit behind in getting an up-to-date prescription monitoring program, but I believe all 50 states have active prescription monitoring programs, and most states have instituted initiatives to get the prescription monitoring program into the electronic health record. So if you're not a prescriber, what that means is that as you're viewing your patient in your electronic health record, you're looking and providing their medications on the computer. Prior to seeing the patient, you can just click a button that opens the patient's prescription monitoring report. Prior to that, you would have to have your patient's chart open, go into the prescription monitoring program, enter all this data, and that could take time and make it less likely that you review that medication. So what the PMP is going to tell you is what medications, controlled substances that patient has filled. And the PMP covers many states. We'll talk about limitations in a little bit of time, but the PMP is a wonderful resource, the prescription monitoring program. You have to register for it as a prescriber. And once you've done that, you have access. And you also can register delegates, because we're always having time constraints. So prior to seeing any patient, review the PMP. And I do it whether I'm considering prescribing controlled substances or not. And also, we're not just seeing our patients, right? If you're in primary care, maybe you're seeing 24 to 30 patients a day. Excuse me. But you're also doing refills. You're doing refills for patients that you might not be the attending for your peers who might be on vacation or out of the office. You're refilling for these patients that you may have never met. And so you're diligently reviewing that PMP before you're filling any opiate prescription. And it is mandated in the state of Arizona. So the PMP, the prescription monitoring programs, definitely one of our most valuable apps resources in the safe prescribing of medication. And so you're going to see a lot of these lovely charts that you can go over in your leisure, like kind of decision trees of how to make the best choices for the safest choices of opiate prescriptions in terms of dosing range and duration. And you want to ensure that the recommended non-opioid practice considers low-cost, safe, and easy access options for patients, like we already talked about, and that your organization is ensuring opiate education, risks, benefits, and alternatives in an understandable way that is in the patient-preferred language. And again, the organization kind of has a responsibility to make this an easy way for prescribers to implement this. One of the ways that our clinic does it is within our electronic health record. We have a controlled substance agreement, and you want to be using that positive health promoting language. Maybe in the past we might have called it a contract, but this is our controlled substance agreement. And on the controlled substance agreement that you can easily pull up in the chart and have the patient sign, give them a copy, it says all the common things, that this is a controlled substance, that you do not share it with your family and friends, that you keep it in a safe place, locked, that you take it only as prescribed, and most importantly, that you don't go to another doctor and receive the same type of medication. So if I am prescribing an opiate for you, you're not going to go into the ER and accept a prescription for an opiate from another doctor. And again, just to talk about one limitation to the prescription monitoring program that not everybody is aware of. So you see all the opiates or benzodiazepines or amphetamine like ADHD medications on there. But if a patient has an opiate use disorder and they are in a methadone treatment program, not being prescribed methadone for pain, but as medication assisted treatment, that methadone does not show up on the PMP, the prescription monitoring program. And for many providers, that is their biggest concern. So the patient would have to be forthcoming. The reason behind that is that the patient is not filling that prescription for the methadone. They're getting it from a methadone treatment dispensary. And so your patient could be on methadone, not disclose that to you, and could seek other pain medication that would not be safe for them. And unfortunately, that has happened to me a couple of times. And there's different reasons behind that, and people acknowledge it as a barrier to safety, and they're working to change that. Another barrier for me in Mohave County is that I practice on where the 3 states meet: California, Arizona, and Nevada. And although most of the states report to the PMP, there are the prescription monitoring program. There are some states like California, I'll call California out, whose laws do not require them to report. And so I can have a patient easily that was picking up medications in California, doesn't disclose that, and they do not show up on the PMP, making it difficult. So it's a great tool, but not foolproof or perfect yet. So when starting, recommendation number 3, when starting opioid therapy for acute, subacute, or chronic pain, clinicians should prescribe immediate release opioids instead of extended release and long-acting opioids. So we want to track and report the extended release and long-acting opioid prescriptions. Like we talked about in the PMP, there is some use for them, but their use should be decreasing, and they're going to be like a last resort option. They're not recommended to be used as baseline therapy. You want to consider longer dosing intervals when prescribing these long-acting opioids to patients with renal or hepatic dysfunction. And you want to closely monitor patients when prescribing methadone or transdermal fentanyl. So track and report these opioid prescriptions like we talked about in the PMP. Primarily, it's the pharmacists that are importing that data. Provide cultural humility. And I like the term cultural humility as opposed to cultural competence. Ensure monitoring tools for the extended release long-acting opiates reflect social determinants of health, and consider allocating time to clarify concerns of opioid overdoses when prescribing extended release long-acting treatment to improve health literacy. And so we definitely want to not take for granted that patients are aware of the danger for accidental overdose and death. And it's excellent that Narcan is available now without a prescription. I believe that's across the country. I still, for sure in Arizona, it is available without a prescription. I still prescribe Narcan to my patients that I'm prescribing. Usually I'm prescribing Suboxone, buprenorphine. But if I have a patient on an opiate, I prescribe Narcan, and I explain the use to them, that you call 911 first, you administer according to package directions. If they're reluctant to accept it, I say you keep this in your purse. You could use it, could save your life. You could save someone else's life. And I've never had a pharmacist come back to me and say, well, why did you prescribe that Narcan? I think it's good practice. So recommendation number 4, when opioids are initiated for opioid-naive patients with acute, subacute, or chronic pain, clinicians should prescribe the lowest effective dose. If opioids are continued for subacute or chronic pain, clinicians should use caution when prescribing opioids at any dosage, should carefully evaluate individual benefits and risks when considering increased dosage, and should avoid increasing dosages above levels likely to yield diminishing results in benefits relative to risk to patients. So you're always doing in your own clinician deciding mind and in a juxtaposition with the patient's the risk versus benefits. And for chronic pain, opiate use usually does not lead to improved outcomes and can bring a whole other slew of problems along with it. So for health equity considerations with this, we want to ensure the use of data that represents the different populations that you serve, including geographic metrics. Consider accessible and preferred tools and methods when implementing frequent communications. And consider language literacy and culture when educating patients and families about pain types and appropriate therapies to improve informed decision making. And I always, as a rule of thumb, like encourage family involvement for collaborative information to make sure. And I think just for safety and for your own liability, making sure if the patient allows it, that we've got that treatment team of the family as a part of the treatment team involved leads to safer outcomes. So recommendation number 6, when opioids are needed for acute pain, clinicians should prescribe no greater quantity than needed for the expected duration of pain severe enough to require opiates. I think the overprescribing in terms of quantity has contributed to many opiate deaths as family members find these extra medications, and it would be a horrible way to introduce someone in the family or someone that has access into opiates and create a lifetime of addiction. Always keeping in mind that we do no harm. Now, it does take more time to prescribe those short quantities because you're going to have to be doing the refills. It does take more time to have that patient come back at more frequent intervals for reassessment of their pain, but really is necessary, if possible, to mitigate those risks. So the health equity consideration here is to ensure that treatments include refills and additional evaluations. They reflect the social determinants of health. And that's always kind of a fine balance, because for elderly people, you don't want to see them going to the pharmacy every week. That's going to be difficult for them, but you don't want to provide more than what they need so that it can end up, doing harm. Provide exposure and training to interprofessional healthcare teams in different cultures and expand their reflexivity and intersectionality attitudes to sharing power with patients when implementing tapering systems. So if the patient feels empowered, all the outcomes are going to come out better. And what patients really don't want is they just don't want to know that you're going to abandon them. They're pretty much going to go along with what you suggest. Ultimately, if you present it in the right way, and if you let them know that you guys are going to go through this together, you're not just going to cut them off and leave them out there fending for themselves. So recommendation number 7, clinicians should evaluate benefits and risks with patients within 1 to 4 weeks of starting opioid therapy for subacute chronic pain or of dosage escalation. Clinicians should regularly reevaluate benefits and risks of continued opioid therapy with patients. And this can be difficult if you are in a busy clinic. Where I live in the Mojave Desert, there are pronounced physician shortages. Many primary care providers come out there as part of federally funded programs. When those programs are completed, they leave. So when you have just a large caseload, lots of patients, it is hard to get them back in for those more frequent appointments, but definitely necessary for safety. And that's when you can involve the whole treatment team to make sure those checks and balances are in place. Recommendation number 8, before starting and periodically during continuation of opioid therapy, clinicians need to evaluate risk for opiate-related harms and discuss risk with patients. Clinicians should work with patients to incorporate into the management plan strategies to mitigate risk, including offering naloxone. So yeah, I'm going to offer naloxone. I'm going to order naloxone. We're going to talk about it every time you come in to see me. And I'm definitely going to make sure it's available to you, and that you do understand the risks are legitimate, and that many people that die of opiate overdose deaths, they also did not want to die, and they did not think that it would happen to them. So number 9, recommendation when prescribing initial opioid therapy for acute, subacute, or chronic pain, and periodically during opioid therapy for chronic pain, clinicians should review the patient's history of controlled substance prescriptions using state prescription drug monitoring programs, that PMP that we talked about. Ideally, it's integrated into your EMR so you can quickly and safely use it and determine whether the patient is receiving opiate dosages or combinations that put the patient at high risk for overdose. So this is another great thing, again, to talk more about the PMP. Not only does the PMP give you that quick data snapshot of your individual patient on a monthly basis, it provides a snapshot of how you as a prescriber, how your prescribing practices line up to other providers in similar circumstances in your state. It also, and very important to me, gives you a list. It'll send you an email and give you a list of any patient that is on a dangerous combination of an opiate and, let's say, a benzodiazepine or another medication that really is not the safest. So for a long time now, I've done a good job at tapering and discontinuing many of my patients on these high-risk combinations off of their dangerous combination with a lot of patience and a lot of time and a lot of counseling. But I would print that list out and that would be there for me to see. And that would be my goal of how am I going to taper these patients so that they're not on these dangerous combinations. So definitely utilize the PMP. One great thing in the state of Arizona with our Medicaid system, if you have a patient that has suspicious or maybe not the safest prescribing, like filling of medications from multiple different providers at different pharmacies, they can put a lock on that patient's account so that the insurance will only reimburse for prescribing from one pharmacy. So the patient can be closely monitored, and that's likely available in a lot of other states. So recommendation number 10, when prescribing opioids for subacute or chronic pain, clinicians should consider the benefits and risks of toxicology testing to assess for prescribed medications, as well as other prescribed and non-prescribed controlled substances. Let your patients know upfront that this is going to be a part of your practice so they don't feel like they're being called out or that it means that you're suspicious of them. And you use neutral language, not like they had a dirty urine. And you don't use it as punitive. You use it like you would any other test, like for hemoglobin A1C, and then use it as a teachable moment to discuss any possible interventions that are needed. Recommendation number 11, clinicians should use particular caution when prescribing opiate pain medication with benzodiazepines concurrently and consider whether benefits outweigh risks of concurrent prescribing of opioids and other central nervous system depressants. So I kind of talked a little bit about this. Opioids, benzodiazepines, along with opioids, in my opinion, have been overprescribed. They were never recommended for long-term use, but have been used long-term. So if they are on these combinations, you cannot just use that as a reason to abruptly stop their medication. You're going to do more harm than good, and you're going to probably introduce someone to obtaining illicit medications on the street. So you are very merciful in your taper. And if you don't feel like you're qualified to do this, this is when you can refer to behavioral health. So clinicians should offer, the last recommendation, number 12, clinicians should offer or arrange treatment with evidence-based medication to treat patients with opioid use disorder. Detoxification on its own without medication for opioid use disorder is not recommended for opioid use disorder because of increased risk for resuming drug use, overdose, and often overdose and death. All right, conclusions and resources. That was a lot. I know I had to talk like really fast to get through this. I hope you were able to take a lot of that in, and there's so many other points I could cover. But in summary, the social determinants of health influence the healthcare provided by the differential outcomes observed. Priorities for healthy communities have been identified by CMS. The 2022 CDC clinical practice guidelines provide overreaching voluntary recommendations on the use of opioids to manage pain. Clinicians, patients, and their families should work together to identify treatment goals, including functional goals, and tailor an approach that considers both the benefits and the risks of available options. So progress should be monitored over time and treatment of protocols adjusted accordingly. And so here's going to be some just really, really valuable resources. And I know I have nearly run out of time, so I am going to go to Miss Torres for any questions or anything that have come up in the chat.
Wonderful presentation, Dr. Mary. We don't have any questions or comments in the chat, but everyone can do that right now. Feel free to ask any questions to Dr. Mary about the recommendations or relevance or any part of the content. And also, we have included a list of different resources that you can share with your team, with your community about pain management and substance use and opioid use disorder as well. These resources are nationwide and statewide. So feel free to take it with you so you can share it with your community.
So one practical piece of advice that I would give if you as a clinician or any other type of the multidisciplinary team are talking with a patient, you know, the words you use and the way you present really matter. And as a nurse, like on the surgical floor, working in med surg, you learn right away how you're going to talk to that patient. And when the patient comes to you and they have in their mind that what they need is opiate therapy, you don't come back with a no, that's not appropriate. No, I can't do that. No, these recommendations say I can't do that. What you come back with is, let me tell you what I'm going to do for you. I hear what you're saying. You're in pain, you're suffering. I sympathize with you and I'm going to help you. This is what I'm going to do. I'm going to get you a referral for PT. We have an office right down the street that's going to help you. It sounds like you're having problems, that your pain's not allowing you to function in the home. I'm going to give you this referral to a CMS case manager that's going to work to help you get services that way. I'm going to get you involved in a pain support group. I think that's going to be helpful. And I'm going to try these medications, you know, and we're going to work together to make you well. But you don't lead with a no. And then you don't return, like when people get upset because you hold the power to give them what they know they need. You don't blame them for their upset. They're doing their very best to get what they believe they need, but you as a medication expert, you don't reflect that degree of frustration and anger, because that only makes it worse. You hear them out, but you stick to what your recommendation is, your recommendation. And you want to always consider at first you're going to do no harm.
Any questions for Dr. Mary or any comments or concerns? No. So maybe we can try and launch the poll function now. We need everybody's feedback. We appreciate your feedback. That's how we're gonna improve and be better next time. So I will try to launch the function. We have 3 questions in our survey, and we appreciate very much your responses. If you can please take a moment to answer these questions. I don't know if we are having some technical difficulties here, but I don't see any responses. Does it show on everybody's screen?
I see it.
Okay. Well, okay. Well, if we don't have any questions or comments from the audience, Dr. Mary, I think we are ready to wrap this up. How do you feel?
Sounds good.
Yes, okay. Well, thank you everyone for joining us today. We will have another series next time. And just visit our website for more information for this presentation, for the recording of this presentation, and resources. Thank you, everyone, and see you next time.
Thank you.
Thank you.